Good afternoon, everyone. I'm Dr. Danielle Johnson. I am the Chief Medical Officer and Women's Mental Health Director at the Lindner Center of Hope in Mason, Ohio. And today we're here to talk about perinatal OCD. Some disclaimers at first is that this is educational and not intended to replace therapy. If you have any treatment-related questions, please work with your provider or talk with a local clinician. You can also use IOCDF's resource directory at iocdf.org /find help to locate a clinician near you. The International OCD Foundation is also not a crisis hotline. If you are in crisis or ever feeling unsafe, please call or text 988, the Suicide and Crisis Lifeline. It's also online at 988lifeline.org, O-R-G. Go to your local emergency room or call 911. We want to create a safe space and be kind and respectful to everyone. At the end of the day, we're here to support one another. A note that this is being broadcast on several social media platforms and is being recorded. And I'd like to allow our guests to introduce themselves.
Go ahead, Cindy.
Oh, thank you, Michelle. Hi, I'm Cindy Herrick. I'm the Senior Editorial and Research Manager at the Policy Center for Maternal Mental Health. We're a national nonprofit working to close gaps in maternal mental health through systems and policy change. Michelle, please.
Hi, everyone. I'm Michelle Lacey. I'm the Executive Director for Women's Health Innovations of Arizona. We are an outpatient treatment center specializing in maternal mental health. We have therapists that all specialize in this, and we bill insurance, including Medicaid, and we utilize peers. I am also a trainer for Postpartum Support International.
Wonderful. Thank you both for being here. So I'm going to start with our first question. What do you think is the state of perinatal OCD in 2025?
Michelle, go ahead.
We're both. So I think it's encouraging. We're having conversations like this, which is so needed. When I entered the field 25 years ago in perinatal mental health, people really didn't understand perinatal OCD. And so we're having more conversations about it and more collaborations like IOCDF and PSI and the Policy Center, so that we can ensure we're providing best practices, which is also so essential in this.
Thank you. Any input, Cindy?
Oh, yeah, I completely agree with what Michelle said. And she's got a lot of experience. I know we have known each other for a while. But, I come into this both from the policy perspective and someone with lived experience. I think from a professional standpoint, we're definitely, as Michelle said, moving in the right direction with research, advocacy, and lifting up lived experiences. Hi, Birdie.
Hello.
And the fact that, as Michelle said, we have partnerships, it's interdisciplinary now, and we have leaders from different areas is so encouraging. It's a much needed focus on the intersection of maternal mental health and OCD, and we're breaking through previous silos. From a lived experience perspective, I didn't know this was a thing when, my son is 13 now, turning 13 years ago. I didn't know this was a thing. And now I see it regularly. Maybe there's definitely, we can never have too much awareness, but we're definitely seeing it more talked about and not as much stigma. So I think we're moving in the right direction.
Yeah, I agree with that. So Birdie has just joined us. Birdie, if you would like to introduce yourself. And the question we were talking about was the state of perinatal OCD in 2025.
Yes, thank you. I'm actually in Jackson, Mississippi, doing a PSI training. And so time zones and whatever, and then I couldn't find a private spot, and then I couldn't find an outlet. So sorry for my lateness, but yes, I am Birdie Gunyon-Meyer, and I am the Director of Education and Training with Postpartum Support International, and work closely. Of course, Michelle's one of the trainers, and I've worked with Cindy for years and known her for years. So we have done a song and dance before together, Cindy and I, and she tells her story, and it is so important to talk about all the things. Perinatal OCD, like we said, we work with IOCDF, and they have put more information about perinatal OCD on their website, which we are thrilled about. because, there's the group of people that really know OCD, and then there's a group of people that really know perinatal mental health, and we want to train each other. We want to help each other because, yes, OCD is OCD, but perinatal OCD now involves a baby. And so then it gets really scary. And like Cindy said, with her own lived experience, and, Michelle and I working with clients, all these years, just the horror that they feel with perinatal OCD. So, Dr. Johnson, you'll have to tone me down because once I start
It's
talking.
okay. No, that input was very valuable. And I appreciate all of your feedback. I do think overall that there's more awareness of perinatal OCD, but I still notice that a lot of people, the people experiencing the symptoms don't realize what it is. And because some of the intrusive
Right.
thoughts are so disturbing, they're embarrassed to
Yes.
say anything. And I think continuing to reduce stigma is so important.
Yes. And our research says, as we have a slide in our training, that still 80% of our care providers don't know what perinatal intrusive thoughts are, or recognize them, or be able to differentiate them from psychosis. So that's why we're here talking about this today.
Absolutely. Thank you all. Moving on, what gains, and we've touched on some of this already, but what gains or improvements have you seen regarding perinatal OCD understanding, awareness, diagnosis, or treatment since you entered the field?
Wow, it's changed a lot. Yeah, go ahead, Michelle.
So as a provider, and I'm also someone with lived experience, and that was 25 years ago, which is, nobody was talking about it back then. But as a provider, what's exciting to see is more and more people understand what OCD is and are treating it with best practices. So we have, and in our clinic ourselves, we are getting clinicians trained in ERP and perinatal mental health, and really marrying those two together so that people are getting the best practices. So that for me, on both sides of it, as a clinician and as someone with lived experience, I love to see that more and more providers are available, and more providers are available at that bill insurance too. And you're going to hear me say that a lot because I really think that people should have accessible care. So we're getting there. We still have a lot more work to do, but I think we are moving in the right direction with that.
Agree.
Yeah, same. I, came into this field in 1997 and that's 10 years after Jane Honickman founded PSI. And there were maybe, 10 to 12 books in the field total on perinatal mental health, which everything was called postpartum depression then. And I knew all the books and had read all the books. Now there's so many books. And so I've seen a lot change just with people telling their stories, even our celebrities telling their stories. I mean, I think the first really great celebrity book that came out about OCD and intrusive thoughts was Down Came the Rain from Brooke Shields, and that was in like 2001. And so many of my clients said, "Oh, that's me. Finally, someone is telling my story," because it had always just been postpartum depression, crying, sadness. And she told this story of anxiety, of intrusive thoughts, of OCD. And it was, wow, that can happen. And so that really helped. So I saw that as a major change. And then the other book that came out right around 2000 was Women's Moods by Jean Driscoll. She had OCD and told her own OCD intrusive thought story in that book. And people were saying, "What? I've never heard of this," or, "Oh, I'm glad she talked about that. It's about time I had that and didn't know what it was, and I was afraid to tell people." So, we've seen clients all these years that come in and still telling horror stories of going to emergency department, maybe being sent to inpatient psych for people that didn't know. And then let me shout out Karen Kleiman. Karen Kleiman writes a book called Dropping Your Baby and Other Scary Thoughts. And that was really mostly for professionals. I didn't recommend it to our clients. And then the best of all that everybody recommends, Karen Clement's book, Good Moms Have Scary Thoughts.
Absolutely.
Yes.
And she had a campaign called Speak the Secret or something like that. It was, come on, everybody start talking about this so that it's no longer a secret.
It is really fascinating that when I go into moms groups and really go through, unpack what perinatal OCD really is, it's fascinating to watch the light bulbs come on and like almost the relief, even whether it's in groups or one-on-one sessions, when people are like, that is it. I've been told it was depression, or I just told I had anxiety, but that's not what it was. That's what it is. And so with being able to have those conversations more now is empowering people. I'm sorry, Cindy, I think I may have.
Oh, no. All great things that I would have said too. So thank you both. I think from a research and policy perspective, we've had leaps and bounds of changes. Just in preparation for this, I was looking at the literature, what's been published. And even just in the last 2-3 years, the amount of literature that has been published in scientific journals about this has been amazing. And, from a policy standpoint, we don't want to just make policy just to make policy, right? We want to make evidence-based, patient-centered policy. And so this is so crucial because, just to name off a few, I'm a nerd about this stuff, so I love this stuff. But, just to name off a few, we've had some more meta-analysis basically looking at different research to see the prevalence rates. And we're seeing that they are going up. They're higher than what we thought they were before, which I think those of us who are in the field are not surprised.
No.
That's so important in policy because not everybody has this insight knowledge that we do and see the mom struggling firsthand. And so we need this evidence to say, hey, this is a problem, and the evidence supports that. And so having things like that is so important, whereas 10 years, 15 years ago, we didn't even know it was a thing, right? And having everybody speak up, as much as Bertie has been saying and Michelle has been saying, so important, because I think what is unique about this is that intrusive thoughts, it can be about anything. And so I think a lot of people don't speak up because they go, well, that's not the typical intrusive thought. That's not maybe this is something different, or there's shame or there's stigma. But the more people share, the less silly, shameful, stigmatic, whatever it is, it can be across the spectrum. So I think that is so important that this is being recognized. And then just on a broader clinical level, Dr. Johnson might be able to talk to, so actually you're all clinicians, but with DSM, with OCD being moved out of anxiety now and having its own category, I always thought it was sort of this thing where I was like, you know what, that makes so much sense because it's not just another anxiety thing. It's very nuanced. And I think that having the clinical and policy and research world sort of reflect what people already know from anecdotally and lived experience is so powerful. Yes. So I really appreciate all the work that everybody's been doing, across the field for these gain improvements.
Yeah.
You just reminded me, Cindy, that of course, I'm all about books because, Michelle and I both, I don't know about you, but Michelle and I read this book, Nerds. And I just thought about Dr. Shoshana Bennett, who's also in this field, called Dr. Shosh. She also had OCD, intrusive thoughts, and she tells her story. And that was a pretty early book, too. She and Heckman, Beyond the Baby Blues. And we use a short video clip of Dr. Shosh telling, because when you said it can be about anything, because Dr. Shosh tells, I walk by a microwave and I think about putting the baby in the microwave and I do this and that gives me a trigger. And so PSI has these short little video clips and they're on our YouTube channel. And there's a video clip of Dr. Shosh telling about her OCD and, trigger warning, she gives thoughts that she has. So, also PSI has OCD support groups. We have a support group for almost anything you can think of, over 50 groups in English and over 28 in Spanish. And we do have an OCD group, maybe a couple of them, I'm not really sure. But in there, they're not all given all their intrusive thoughts, because if I have intrusive thoughts and you have intrusive thoughts, you give all of yours, now I'm stuck with all of yours besides my own. But we can all just talk about intrusive thoughts in general. And so more and more, we are having more acknowledgement more places to talk about it, take away that shame, and get more information out there.
And I'll add, since I started in this field, I finished residency in 2008. Very little perinatal training during residency, but I'm noticing now that residents, medical students know about maternal mental health disorders. A lot of them are already interested. They know that's the field they want to go into, and they're looking for as
know,
many
I love it.
opportunities as
That's
possible
awesome.
to get that education. But the education is more readily available in most residencies, whereas before it was not. So I think that leads to a higher number of general psychiatrists feeling comfortable at least starting treatment before someone needs to get to a reproductive psychiatrist.
Yeah, wonderful.
Yes, more and more training. I know they're talking about wanting to have it as a specialty. There are those who specialize, and more and more people are wanting to specialize, which warms my heart. But we still have a lot of med schools that still need to include training, and residencies that still need to include training, social work school, counseling schools, nursing schools. We still need to be including training on perinatal mental health so that we have people coming out knowledgeable about this field.
Right. And if there is anyone on here from, sorry, didn't mean to interrupt you. Anyone from a residency program, if you're not already familiar with NCRP, the National Curriculum in Reproductive Psychiatry, that's available to teach your residents about from, PMDD to perimenopause and including perinatal issues. It is a really comprehensive and thorough curriculum.
Yeah.
I'm going to move on to some of our questions in the chat. Are there any etiological differences between perinatal OCD and OCD in general? I can start with that one if you're okay. So with perinatal OCD, it commonly appears for people who are permiparous. It happens in their first pregnancy. It is more common to occur postpartum than during the perinatal period. And also for women who already have a history of OCD, up to 70 to 80% of them can experience exacerbation of their symptoms during pregnancy or after pregnancy. So it's thought to be hormone related, of course, significant drops in hormones after pregnancy. However, fathers can also get perinatal OCD. So for them, it's not hormonal. It's thought to be just the intrusive thoughts that the majority of parents already have about parenthood escalate when we're thinking of paternal issues, or they may already have a prior history of anxiety, but for paternal, the intrusive thoughts just become impair functioning, basically. So there is some hormonal component, but not for everyone.
I think it's really important whenever I work. I love that. I mean, thank you so much for focusing on that hormonal significance too, because I think what happens in the perinatal period is we just kind of have this expectation that we're going to have this baby and we're going to just keep going, but we don't recognize the vulnerability that we have as a result of the significant hormone shifts, the sleep deprivation, the adjustment into this new change. And if we have a vulnerability or a history, that's going to come up and look very differently. And with OCD, what we see is so many people have been diagnosed with anxiety throughout their whole life. And then all of a sudden it looks very different and it feels very different. And what they really have missed was that they had OCD most of their life, but they were just looking at the anxiety. So I always talk to people about the importance of understanding what's driving that anxiety throughout your life. And because if we don't do that, we just perpetuate the suffering. And I think so we have to, just normalize that this perinatal period is one of the most vulnerable times in a person's life. And all that stuff that we have been white knuckling or pushing aside, it's going to come up to the surface one way or the other. And so we have to deal with that. And I think if we can begin to look at it in that way, we can take the stigma away from it, that this is not about will or just try harder or just be a good mommy. It's about, like, there is some there's a lot happening to my brain and my body here. And now we need to address it during this very vulnerable time. I can
And good point. Yeah, good point, Michelle, that you brought up, that whatever we already have, and if you don't know it, we all have a diagnosis, okay? None of us come with a clean history. We all inherit what we inherit from both sides of our family, but you need to know what you have and be the best you can be with it, but we don't always know. And so either parent, as we were saying, can have OCD, intrusive thoughts, but what happens is now we have a fragile human being. And so whatever you had before now ramps up during pregnancy or postpartum, and it can be either parent. So, okay, so some of the studies show, like, what, 88 to 90% of us have intrusive thoughts after the birth of a baby. You're worried. What if I drop the baby? What if the baby? What if? But those who actually have a diagnosis of OCD, that goes on to be paralyzing, goes on to, get in the way of functioning, whether it's with contamination, whether it's with the what if, those thoughts that come out of the place in your brain that wants to protect your baby. And it's taken and twisted and said, what's the worst that could happen? Mm-hmm. And then they have the images, the pictures, the thoughts, the stories. And we know common triggers, right? They're heights, sharp objects, water, traffic, sexual thoughts. Those are just some of the most common. And like Dr. Johnson said, typically more common in postpartum, but I will tell you, I've had clients who had had a history, didn't know that they had a history, and then suddenly postpartum start having these intrusive thoughts, and so they come to see me. Well, some of those same clients, after we get through the education and the treatment and whatever for it all, then the second time they get pregnant, I get calls like this: hey, Birdie, they're back. Mm-hmm. Those intrusive thoughts are starting in my pregnancy this time. Yes, they are, but they didn't have them with their first pregnancy. First time they didn't have them until postpartum, but now it's always funny. They're back, Birdie. Yeah. But that goes the education, right? To know what they are, not be ashamed of them, know what the treatment is, and know what they're called. And like we've all said, it is not your fault. As our motto in PSI, you are not alone. Perinatal mental health affects 1 in 5 to 7 women, 1 in 10 men. You are not to blame. This is caused from risk factors. And yes, hormones are involved, but mostly risk factors. And with the proper treatment, you will be well. And if we send people to clinicians who have not been trained in perinatal OCD, especially, they can really mess them up because they don't understand it and they don't get the right treatment.
Absolutely. Yeah.
And when you think about, I just want to add, if you think about both parents having intrusive thoughts, let's say they both have OCD. Oh. Wow. That's
fueling.
Yes.
Totally.
Yeah. And I think too, recognizing that even those with a history of OCD during the perinatal or postpartum period, the content is so different.
Yes.
Usually. That they may not recognize it. Oh, this is my OCD, because the intrusive thoughts are so completely different than what they've ever been in the past.
Absolutely.
And I think the other piece of that, if you go into the rituals or the compulsive behaviors, it can really be missed in perinatal people because they can be disguised as, I'm just being a good mom. Mm-hmm. I'm researching because I'm trying to figure out what's wrong with my baby, or I'm reassurance seeking or checking or doing all the things because I'm making sure my baby is safe, and they can justify it. But as we unpack it and talk about those things, what we realize is, oh, I'm researching for 3 hours and I'm still really heightened and anxious because I'm not feeling the relief that I was thinking I was going to get. And I thought I was just being a good mom. And this is what good moms do. and they're suffering in it, right? So we have to have that conversation too, which I don't think as many people do, but also then it really educating people on the mental compulsions that can happen. Because when you do, because people, that gets missed often, right? We're looking for the washing of the hands and the ordering and the checking of things.
Right.
We want to really educate about the mental checking, the reviewing, that how much time are we spending, playing out the script again.
Yeah, I see some follow-up questions about the hormonal changes. Are the hormonal changes one of the multifactorial causes or a trigger that sets it in motion? I think a bit of both, actually. It's definitely multifactorial, but definitely the changes in hormones, particularly oxytocin and estrogen after pregnancy, are a trigger to make you more vulnerable during that period of time. But there's still, all of the other factors that can go along with it. Your previous psychiatric history, your family history, stressors, trauma. There are a lot of other risk factors involved as well.
Yes.
I know we've touched on this a little bit, but we can go into more detail. What challenges are we still facing with perinatal OCD?
Accessible care. accessible care and best practice care, because it oftentimes will get missed. Especially if someone is not really doesn't understand the perinatal piece and the OCD piece together. And so that's a big challenge for a lot of people. And finding someone that does ERP and understands perinatal mental health that also bills insurance or Medicaid is like finding a unicorn. So I think for me, I would love to see more of that integrated into our perinatal health care.
Absolutely. I think from a policy standpoint, we concur. Absolutely. There's not enough people trained in the workforce. And then obviously the reimbursement piece too is something that not just OCD with, just throughout perinatal mental health services, but definitely, since it's a specialized area, we recognize that. I think on a broader spectrum, training for people that work with moms, whether it's child protection or, emergency. Yeah, things like that. So where people, I think within our field, we're seeing a lot of progress. Externally, there's still a lot more work to be done so that people don't hear these scary thoughts and think, oh my gosh, we have to take baby away, or oh my gosh, we have to call the authorities, which we know is a cascade of trauma that they don't need, additional trauma that is not needed. And so I think those two main points.
Absolutely.
Yeah, good point, Cindy. That's part of it, is still knowing anyone who crosses the path of a pregnant postpartum person, baby, with a baby, family, spouse, partner, they all should be trained in perinatal mental health, and especially what perinatal OCD looks like. Because, like you just said, add on to the trauma by calling 911 or sending them off in an ambulance to get them to emergency department or inpatient psych referral. And then it takes hours. And then finally somebody recognizes what it is, and we've traumatized them. And we still have too many of those stories, sadly, where someone says, I knew if I told this was going to happen to me, or having DCS called on them. And that just takes a while to get all around, which she wasn't a bad mom, but we just made her feel like one by finally, telling her story and telling her thoughts. And now she gets punished and traumatized for that. Right. And especially the last usually intrusive thoughts people are going to tell you about are the sexual thoughts that they have.
Yeah. And I think it's so important from the clinician side to understand the difference between intrusive thoughts or obsessions and delusions, because it's going to lead to a completely different outcome. And
Right.
completely different treatment is required. There, you could actually just Google obsessions versus delusions and see,
Mhm.
see a comparison chart. But I think one of the biggest things to distinguish is that for people with OCD, they are bothered by their thoughts.
Mm.
Their thoughts are very unwanted. When people have delusions, they often do not recognize that the thoughts are not real and often not bothered by them. When someone has an intrusive thought that might be disturbing about harming their baby, they know that they aren't going to act on it or don't want to act on it. Whereas with someone who has psychosis, they might act on it, or
Right.
they're at higher
Yeah.
risk for acting on it.
Right. So just to distinguish, we teach this in our trainings, of course, that number one, if you're wondering, is this an OCD intrusive thought or is this psychosis? Is this a psychotic thought? And bottom line, like you just said, Dr. Johnson, are there delusions or hallucinations? And if there are, it's not intrusive thoughts, it's psychosis. But keeping in mind that there are times when someone with a psychotic thought might be scared by those thoughts. And I'm going to give an example of one of my clients. She called me up in the morning and she said, Bertie, last night I was holding my baby and his eyes started glowing. And I thought he was demon possessed. And I said to my husband, take the baby. His eyes are glowing. I think he's demon possessed. And then she said to me that morning, that's not a normal thought, is it, Bertie?
Mm.
So is that an intrusive thought? Absolutely not. Was she afraid of it? Yes. That could have been a horrible outcome. But that's with psychosis, waxes and wanes. And if we don't catch it in the waxing and waning, then sometimes we hear the horrible story of they really believed their baby was demon possessed. But that's not a what if thought. Intrusive thoughts are what if. What if I drop the baby? What if this? What if that? That's not what if. That is, I see my baby's eyes glowing. I think he's demon possessed. That's not a what if. And we don't have what if thoughts about your baby being demon possessed. So that's the difference. But sometimes we've known people who got missed even with psychosis because they've been asked, are you afraid of your thoughts? And they say yes. And then they don't ask them what the thoughts are. And they say, oh, well, then you just got OCD, because if you're afraid of them, it's not psychosis. So we must ask more questions. And let's not forget, there is a HRSA hotline, Maternal Mental Health Hotline, and it's answered by PSI trained counselors. And if you are with a client and you're saying to yourself, I don't have a clue if this is OCD or psychosis, you can call the hotline. Someone answers 365, 24/7, and you can say, here's what's going on. Can you please help me? And they will be happy to. So what's the number? 833 TLC MAMA. Okay, 833 TLC MAMA.
And I think that's really so important to recognize that resources available, because when this is presented in a physician's office or a therapist's office that is not familiar with perinatal mental health, all the people tend to see is that baby, and they freak out. And then we have that DCS call or hospitalization, or telling them when the thoughts stop, you can get out of the hospital, which is something that happened here in Arizona. So, and she had OCD, right? So, I mean, utilizing that resource so that you can consult is such a great resource that we have today that we did not have for so many years.
Yes. Yeah. I'm going to go back to the chat, and I probably will not get to all of your questions. I'm trying to pick a good sample. Are there examples of exposures you find commonly help parents with OCD and the themes of harm to others, scrupulosity, or contamination? So
okay,
more from
Michelle
a therapy
gets
standpoint.
Michelle gets this one because we're both trained. She and I are both trained in ERP, but she took it a step further, and she really is trained in supervision and consulting and did the whole thing. And she does see patients frequently. So please tell us about, I love to hear about, because people are so confused about what is exposure and what does it really mean? And can we keep reassuring someone, you're not going to do that, you're not going to do that, you're not going to do that. So tell us about that, Michelle.
So I love doing ERP, especially with perinatal people, because it's so beautiful to watch the healing happen and the relief come. Remembering that exposures are utilized to learn to tolerate the distress, right? But we're not, if I'm having intrusive thoughts about when I walk past the microwave, we're not putting the baby by the microwave, or we're not putting a knife by the baby, right? We're really looking at what's happening for that individual. So for let's say contamination, we do our hierarchy around that. I did a hierarchy. I had a client who stopped cooking because she was certain she was going to poison her baby. And slowly we did exposure. She had rituals and routines around how she stirred the pasta and what she put her spoon on. So we slowly broke it down and exposed her to not using disrupting that ritual or routine. This was so beautiful because as we continued to do that on the hierarchy, by the end, when I brought her husband in, because we were getting ready to do an exposure that he was really a ritual, or exposure around a ritual he was participating in. So we had to really talk that through. I watched her give her toddler now a puff. It fell on the floor. She picked it up, put it back down on the table. The baby put it in her mouth and she didn't even flinch. Mm-hmm. But so that's the power of it, but you have to really break it down and go individually. I've done a lot of imaginal exposures as well, around death, dying of my baby, or the sexual intrusive thoughts. But we also have to understand, what is that core fear, right? We want to understand what that core fear is so that we can know what direction to go in. So I wish I could give you more details, but what we don't want to do is say, oh, they can't be around the knives, so we're going to just have them hold the knife and hold the baby. No, we're not going to do that. Because we have to follow the protocol. Like, I'm a stickler about that. I'm EMDR trained, I'm ERP trained. Follow the protocol because that's what's been studied, right? And the other thing I would also say is, as we're unpacking and understanding the presentation of the OCD in the perinatal period, what we might find is that some parts of driving the intrusive thoughts are trauma related, right? So then we have to decide, what are we going to focus on first? And again, I can talk about that for a while, but I don't want to continue.
Well, and let me give an example there. So I'll add on to what you're saying is, we don't ever totally take away that thought of what if. What you're teaching in ERP is learning to sit with the discomfort. Correct. And yet be able to function. So to be able to be in the kitchen and cut a tomato with the baby right there, and maybe you will have a thought and you say,
there it is.
OCD thought, there it is.
Perfect.
And what you're doing in therapy is imagining you're in a kitchen, you're cutting a tomato, your baby's there. Tell me how you feel. What feelings are you having? So that's what you do in therapy, not like Michelle said, we take them straight to the kitchen, hold a knife, have the baby right there. And that's what people imagine exposure is. So yes. I'd like to really point this out. Do not do exposure therapy unless you have been trained.
Correct. Because that's what we're talking about, is people are like, oh, well, that's what you're afraid of. Let's expose it to that. So we have to gradually introduce it, and gradually then you learn to tolerate that distress. So whether it's I'm holding the baby or someone's holding the baby in the other room while I'm cutting the tomatoes, and then they move closer, it has to work for the individual too.
Yeah. And can I throw in, Michelle, and you talk more about this, but we do have a connection of 1 in 3 women have been sexually abused. 1 in 8 men have been sexually abused. And so when we talk about intrusive thoughts, the sexual thoughts, you throw into that they've got that trauma history and they're getting ready to change a diaper and they have a thought. Some of that comes back from their own trauma of, oh my God, what if this happens to my baby? What happened to me? And it's not an automatic, that's how they're thinking. It just happens. And then they think, what if I did it? And then that's that intrusive thought that is so embarrassing and afraid to admit that, and who would have a thought? They always say that. Well, who would have a thought? As our colleague, Dr. Kat Kayeni says, why couldn't I have thoughts of unicorns and butterflies instead of these thoughts I'm having?
Yeah.
Right.
And
now I'll add that. Oh,
go ahead. No.
Adding that as a prescriber, when someone is going through ERP, you want to collaborate closely with their therapist and also check in with them on how they're doing, because ERP can cause more distress initially.
Correct.
They can become more anxious. It's very effective, but it can be difficult to go through. And so I, closely want to monitor how they are responding and if their symptoms are increasing, because that might help determine if we need to adjust medications during that time or not.
Dr. Johnson, thanks for that, because sometimes we need medication to be on board before they can even start ERP. Right. And it's hard for someone with stigma around medication. Oh, I shouldn't need that. And yet you wouldn't argue with me if you had high blood pressure. That's what I always say. Would you argue with me right now about starting on medication if you had high blood pressure? Would you just take your chances and have a stroke? Well, no, Bertie, but that's it. Is your head attached to your body? I think it is. And we need to treat this. And there are many patients, and I'm not a prescriber, but I'm going to tell you something about that I know that you know about prescribing that I'm not sure a lot of prescribers know. And that's because I teach all the time. But when you have just depression or anger and irritability, 20 milligrams of Prozac or 50 milligrams of Zoloft is going to help. But when you have OCD, intrusive thoughts, anxiety, you may have to take that. And I'm just picking two meds. They're not my favorite meds. I'm not calling out those meds, just saying they've been studied for over 40 years. You have to take the Zoloft up to 100, 150, 200, 250, or the Prozac up to 40, 60, 80. And many prescribers are like, what? I've never heard of such a thing. And so that's another thing where if you send them to the wrong person, they can get messed up. Remember that we have a psychiatric consult line with PSI. They can call in and we will hook them up, a prescriber. We will set an appointment in 24 to 48 hours. You can talk with someone, and that's when you're going to find out, oh, you're going to need to increase that medication. Also, a lot of our states have access lines. So check and see if your state has. I'm in Indiana. We have CHAMP, which is our access line. Everybody has cute names for it. Michelle, I know you have one in Arizona.
Called APAL, and they're live 8 to 5 every day. So you'll get a reproductive psychiatrist to consult with. So if you're not sure, because again, this is that perinatal period is a very, it's different. It's different. It's a different time of treating. And so we want to make sure we're doing the best possible way we can.
And don't forget the partners.
Correct.
And I think a way, Dr. Shosh said this years ago on a video, and it's just a great way to ask it and commonize it, is to say, sometimes new parents have scary or unusual thoughts. Are you having any scary or unusual thoughts? You see how I commonized it first? Just like, oh, it's very common. Are you having any? And they might say something back to me like, yeah, I keep thinking, what if my spouse dies and I'm left to raise this baby all by myself? Common scary thought, but that's not an intrusive thought. Or they might say, oh my gosh, Bertie, I can't say them out loud. They're so awful. You're almost sure now this is going to be an intrusive thought. And you're like, yeah, you can tell me. Let's talk about it. They're really common. But then again, it could be psychosis, and we're going to find that out too. But we're going to check further on that.
Another question, is OCD more common in certain professions such as medicine, where providers see so many bad outcomes and are frequently needing to anticipate problems? I wish I had statistics. I don't, but anecdotally, very common. Med students, residents, physicians, attorneys, engineers. I've seen a lot of people in very high stress positions with perinatal OCD, particularly for people in medicine. Yes, their intrusive thoughts are often related to their career. So yes, I would say the answer to that is yes. I just don't have actual statistics.
I don't either, but you're right. Anecdotally, I've had clients over the years who worked for DCS, And when they had their first baby, literally just couldn't even work in DCS anymore. Said they have so many thoughts from all the cases they've seen over the years of awful things that can happen suddenly come flashing in their head. So that's a career where it would give you lots of thoughts. And yeah, I think, like you're right, medical profession, attorneys, we have these things that we see in our lives, and then you have your baby and you're like, boom, 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 boom. What if, and not necessarily even, not everybody has an OCD diagnosis, but with that OCD diagnosis, like I said, it can become paralyzing, affect functioning.
What do you think still needs to be done to improve the awareness, understanding, and treatment of perinatal OCD moving forward?
Keep having things like this.
Yes, that's exactly what I was going to say.
Yep.
Absolutely. And, you know, I have to say, I attended the ICDF conference this year, which was amazing. And I was so thrilled to see that there was a breakout on perinatal OCD and continuing to do that. And I really think that I think PSI, ICDF, the Policy Center, continuing to work together to put out there more information and training, and however we can work together then we can meet the need even greater when we're doing it together.
Yeah, and as I mentioned earlier, although I think residencies are doing a better job at incorporating maternal mental health into training, it needs to be across the board. It needs to be a required part of residency training.
And nursing and social work and counseling. It's just got to be included. I always say we need to go back and start teaching it in junior high, middle school, about perinatal mental health, because if the numbers are this high, it just needs to be taught everywhere.
Yes. Yeah, I think we might have time for one more chat question. It's another therapy related question, and we might have touched on it already, but I think I like it, so I'm going to at least read it anyway. I'm often frustrated by watching the wide array of non-evidence-based approaches that therapists are using with perinatal OCD. Are there current campaigns happening to educate clinicians?
I don't know about any campaigns to educate clinicians. I think, you know, some things like this, and when we train a PSI, we talk about evidence-based treatment modalities. I think there's some barriers for people getting training because of the expense and time off and things like that. And there's so many things to choose from, right? So I think people have a hard time with that. I mean, I would love to see a campaign of some sort for us to help really focus on, especially with perinatal OCD, understanding really the marriage of the perinatal piece and OCD. And I don't know, maybe we can come up with something like that, because it's definitely necessary. Going back to what you were saying, you know, and talking more, like going back to junior high, anyone I see, family members, anything, I will talk about perinatal mental health, but I will definitely talk about perinatal OCD, and I don't care. And they look at me like, I'm only 15. Why are you telling me about this? But it's okay, because you can, like, I think we can start on that micro level, but I think we do have to do something on a macro level of getting some information, more information out there, because when you're trained appropriately, like when you're trained in ERP, you hear it in very differently. And my staff here will say, how did you get that from what she said over here? The ones that are trained in ERP hear it very differently than the ones that are not. So the additional training certainly helps you hear it in a different way.
And ERP, Michelle, it's a form of CBT. It's an extension of CBT, and CBT works great for those automatic thoughts, right? Like, I'm a bad mom. Correct. That's an automatic negative thought. I'm a bad mom. Okay, what's a good mom look like? And we use CBT to work with those automatic negative thoughts. But using CBT just by itself for intrusive thoughts isn't going to do it.
No.
And so that's why the further training in ERP, and we do teach ERP as the gold standard. And there's just so many therapies out there. And I know that's what the question is about. There's so many therapies out there, and not everyone is trained in ERP or the proper way to treat intrusive thoughts. And so, just to keep getting the education out there, and we're doing our best to do what we can do, and doing things like this to get the word out. And we have resources for taking training in ERP in our 2-day training and in our advanced psychotherapy training, which we're teaching today in Flowood, Mississippi.
That's great. Is there something similar for therapists as far as a consult line like there is for prescribers?
So my first thought, no, there's not a consult line. Our consult line, psychiatric consult line, are for prescribers. But if you're a PSI member, you have access to free consultation. As a therapist, we have groups. As a prescriber, we have groups, and for doulas. So those kind of things are talked about in our consultation groups. The other is that we have, when you're a member, we have listservs where you see cases discussed. And let me shout out to Mass General Hospital, has grand rounds every single Wednesday from 2 o'clock to 3 o'clock Eastern time. It's on my calendar. I don't like to miss it. I'm going to miss it today because I'm here training and I cannot get on. But if I am not doing something else, it is on my calendar every week. You will learn so much. They started grand rounds virtually during COVID, and then they've just kept it up. So we've got Dr. Lee Cohen and Dr. Marlene Freeman on there every week, reproductive psychiatrists discussing cases, discussing things just like this, and people bringing in tough cases. So that's what I can think of. And then our local access lines too. Therapists can actually call there, but I think probably it's more for prescribers. But consultation groups, getting a supervisor, getting a consultant is the best way to do it, especially with ERP training. That's something that's absolutely recommended to continue on with a consultant and supervision.
Thank you. So it looks like we are near the end of our time. Did any of you have any final words?
I just want to add on that there is a Perinatal OCD resource center that Policy Center and I think Bertie worked on it. A lot of collaborators worked on creating this. It's at IOCDF. And just to sort of tag on that last question about, there's core competencies by clinical professions in there under clinical resources. So that could be helpful for people who are looking for guidance and additional training stuff in there.
True. Thanks, Cindy. And NOCD also has information. They have once a month a free webinar, 1 hour webinar on usually something with OCD. You can find lots of free stuff.
Yes. Well, thank you all for being here today and for this great conversation.
Thank you, Dr.
Thank you.
Thank you. And I hope those listening learned, and that, you can take this information with you to help yourself or others who might have these symptoms. And I believe some resources have been put in the chat and will be put on the screen as well. Thank you.
Thanks. Thank you.